take the minutes from the recording. I don't know to what degree the microphone's gonna pick us up or not, but I just want to think about that.
Okay,
I just double checked with one of our audience members and they can hear.
Oh, okay.
they
perfect.
can
That's
hear
good,
us?
They
that's good.
can.
Okay,
If they can hear
They
you
can.
talking, then you'll be fine, because everybody says I need to talk louder.
okay.
Not everybody.
Oh, good call.
Usually not too quiet, but if I am, please let me know. So our next item is approval of the agenda.
So moved.
Second.
All in favor?
Aye.
Any opposed? Any abstentions? Okay, the agenda is approved. The next item we have is review and approval of the minutes from February 5th. Do we need any discussion on that? Can I get a motion?
So moved.
Second? Second. Thank you, Meg. All in favor? Any opposed? Any abstentions? John? Okay, so the meeting minutes are approved for February 5th. The next item we have on the agenda is the member announcements.
This is where you want to get feedback from other things we've done over the month.
If it's in the committee section, you could do it then. If it's not, then yes.
Okay, so I attended the Opioid Coalition meeting last Friday. Had some Zoom issues, so it got off to a slow start. Previous two had been canceled, so some people lost, some people may have already been there. Just kind of bring everyone up to speed on the Opioid Coalition. There's 6 objectives they have. I'm just going to quickly read them off for you. Increase awareness of opioids, their dangers, and prevention opportunities. Consider a focus on a number of different areas. Increase awareness of substance use services available in Yolo County. Increase the availability of substance use services in Yolo County. Increase availability of and access to overdose prevention materials. Reduce stigma associated with opioid use disorder. Increase availability and awareness of syringes, including safe disposal. So the current objectives, a lot of those should sound familiar that we're trying to do with mental illness. Now that we're the Behavioral Health Board, we really need to link that in. I would ask on the director's report, if it's possible next time, to kind of get an overview of opioid overdoses and deaths from overdoses. I'm not sure how far back we can go, but we kind of show this membership, the trends that we're having in Yolo County. And I think we can do that without pinning down co-occurring disorders or age, just kind of a general overview if that's possible.
So the request is to get a report out on opioid-related deaths.
Overdose, yes, and then overdoses. So if someone overdoses and they're Narcan, they're revived and they go home, we have an overdose. I think they may be down last year from the previous year. I think it's helpful for this board to kind of get an idea as we take on this new responsibility.
Are you asking for deaths or related deaths? Just.
I think we'll.
If there's a technical difference there, I don't know what it is.
I think-
I just want to make sure I'm clear what you're.
So what I'm taking here, and you correct me if it's not what you want, the request is for a report out on opioid-related overdoses and deaths.
Yes.
And going back to this.
I don't know.
We'll go back a reasonable time frame based on the available
Yes.
data set that we have.
I think that there's a trend, and I may be going down, but I think that we need to know what that trend is. And I would also think at some point, when we're looking at presentations to this board, we should have a larger presentation on the
Okay.
whole treatment system, medication-assisted treatment, what's available. It's kind of an overview.
It's a good idea. I would see a snapshot of that at the districts. How each district is affected,
And I
where the
think-
heavy use. and stuff like that.
I will see if that's possible. I'm not sure if they're, because I have a feeling we're going to be requesting public health data.
Yeah.
So, but I'll see if there's district level data as well.
I believe that the county's tracking that information already. And so hopefully, I'm not asking you guys to go get anything else that you aren't already tracking.
We will definitely look into it. Meg, is there something that you wanted to visit a little bit?
No, I'm just going where you were going, I wasn't sure if it was public.
Well, I'll have to look. I know that, part of the county's effort to distribute Narcan, there's supposed to be some sort of data collecting mechanism that's connected to that, but I've not, I think part of it is we're not 100% sure how efficient it's going to be. And then also, a member of the public can get Narcan out of one of the
Vending machines.
out of one of the vending machines. So it's a really weird scenario where even when we were trying to develop our internal policy about how to distribute it to staff, we were going around for a very long time, and there was a lot of, fine combing the policies and the agreements you're making when you distribute Narcan to people, and people have to agree to certain things. And part of it is like reporting back, and then, then we have some that are in a vending machine that anyone can get. So, we will look at all available data sets that are, and we'll come back with something next month.
Yeah, I think that there's different treatments available, different districts and different cities. So, but that probably for later, I just want to try and get an idea for the overdoses and deaths.
Sure, okay.
Also kind of limit to that without creating too much of that.
So we'll look into opioid-related overdoses and deaths, if there's any identifiable trends, discussion on local treatment systems, and include medical.
I think we
Medicated assisted therapy, and is there district level data available, right?
So I think we do need to have a larger presentation in the future.
I think that we can talk to our SUD coordinator about maybe being here for the next meeting and kind of presenting out a little bit more detail if that's something that's on your agenda for next month.
I think we should be doing it as part of our board mission now, but I think also just, maybe high level, also understanding what other substance abuse issues we have within YOLO would be important for this board too.
Yeah, that's something I've been curious about because it seems like we never hear about meth anymore. We only hear about opioids.
Right.
So, the broader problem.
Yeah, you do have fentanyls now mixed in with methamphetamine, it's mixed in with other things. So it's,
Interesting.
Just some education in that area.
Okay. Are we talking about just sort of general education about what types of substances are out there, or if we can find data that's related to what specific substances we're seeing?
I think we need a general overview of
Okay.
substance use disorder
And what we do.
in Yolo County, what treatment options are available.
Okay.
Probably a 30,000-foot level
Yep.
overview. So I think anything else is going to overcomplicate things. But there's a lot of things that have been done over the last couple of years. Medication-assisted treatment wasn't available in the jail. It's now available. There's a transition program. It's a lot of advancements that have happened.
Okay.
Any other member announcements?
I wanted to bring up that, so last Monday, there was a joint UC County City meeting. And then one of the topics of the meeting was Crisis Now. So I attended, gave public comment, both written and then also spoken. But my written public comment, is public, and it's like a policy brief on crisis stabilization units, the importance of CIT training, and then observed gaps in the current Crisis Now system. And Nithya also attended, so that's my update.
Would you be willing to share that for
Yeah,
Christina? Okay,
Yeah.
great, so then we can post it.
Maria, so I'm in receipt of this material that Kimberly gave me, which I appreciate, and would you like us to receive it as correspondence?
Oh, sure. Wait, you only have a few copies though, are you wanting?
So, yeah, I also have a Google Doc version. It's
Okay, perfect.
Yeah, if you could email that to us, that would be helpful, just because we can scan it and post it on the website, but having a digital copy is always preferred.
Yeah.
Okay.
If you're looking for correspondence, I can give you the objectives from that meeting. You can get them.
Oh, yeah,
You should be
that would be
internal
good
to
too.
what they put out, so everyone has a copy.
So will that be part of the minutes, or is that something we could have access to?
So it should be attached probably to the minutes. Christina's not here, so I can't really ask her, but we can ask in the form of the recording. Christina, the digital copies will be coming your way, both on the announcement that Chris made and Kimberly, and if those could be attached to the minutes, that would be great.
And just a second, Tony's suggestion that if you can submit them digitally, that would be
Yes.
wonderful. That would
Yes.
make it easier. So Chris, if you don't mind doing that too, that'd be great.
I just have the one copy.
Oh, okay.
Okay, yeah, well,
We
we're
can
not,
take
I know
that.
that I can get an email.
we
to
can make
Julie.
a photocopy, we can make a photocopy before you leave or something, you know?
Well, if you just take a picture of their phone and email it to you.
That's fine.
It was the handout.
It was a handout from Julie. We can get it from Julie.
Yeah. Okay.
Absolutely.
Or it was from Glenn, not sure.
Okay.
They were both there.
I wouldn't mind adding in something. I wanted to offer praise to our county because we have business as usual, and I know you guys seen on the news about Sheriff Cooper. They're no longer doing 5150s anymore. And my daughter was missing for about 4 to 6 weeks and was caught up with them a few times, was found a couple times, and they never did anything to help her, and it wasn't until she was hospitalized and the Yolo County team met up with her, that got her back into safety. And she's back now in aborted care and she's stabilized. So I'm just really proud of our county and all of the people that work in our county, because 3 miles away from where I live is Sac County. And I know that they have their struggles. They have a much higher population to serve. So I'm sure that they're probably trying to come up with something that they can do. But I did have a short conversation with Sheriff Strange, and he said that we were going to continue on doing 5150s in our county. That was like about a month ago. So I'm hoping that we do continue with that and that we don't take the stance. And I don't know if anybody's heard anything different. Tony, you're scaring me.
Right.
Look on your face.
This is the first I'm hearing of any kind of conversation like that, so, I mean, definitely, there's been no conversation that I'm aware of that we would not be doing 5150s.
Yeah,
So, and also, when you say Sacramento County is not going to do 5150s, do you mean that law enforcement would not be involved?
law enforcement will not be involved. And, in all honesty, I don't know if there was anybody out there that are still doing that. There was no teams downtown Sacramento that were doing that.
My understanding, and I don't have a lot of information about this, but I believe the Sacramento County Sheriff's Office had released a press release essentially stating that they would not respond to any more behavioral health only calls. So if the source of the call is related solely to a behavioral health issue, they said, we're not gonna go to that, right? And so, I don't know that any of our local law enforcement agencies are planning to follow suit or anything like that, but I believe it's due to the mobile crisis response model that's being implemented more fully within certain communities. So we have a mobile crisis response model. We still will involve law enforcement when it's appropriate for safety reasons, right? But the idea is not for law enforcement necessarily to be the lead in the interaction. The idea is for our mental health response team to be the lead in the action. And for law enforcement to lead if there's no reason for them to be there. So again, there's been no conversation locally that I'm aware of that we would change anything about what we're currently doing or that law enforcement's taking a different stance.
No, I wasn't saying he was taking a different stance. It was just a personal conversation with him.
Oh, I see.
And we
Okay.
were having a discussion about some of the changes that was happening, and it appears that, that we're not the same as what Sac County is doing.
Mhm.
So I hope I said that correctly.
I-
Did I say it correctly, or am I saying something incorrect?
Understood you to say it was Sac County.
Sac County
Yeah,
Sheriff's
yeah,
Office,
Sac
not
County.
Sac
Yeah.
City PD.
Yeah, that's
or
what
any
I was
other city
wondering.
police
Yeah.
department is not controlled by Sheriff Cooper.
Right.
And Rob Strange is the chief of West Sacramento,
Right.
not the sheriff.
Okay,
Just for
that's right,
clarification.
chief, that's right. Okay, thank you.
Yeah, I mean, I think they still would do 5150s if they have to. They're just not making the model switching to mobile crisis, which honestly is what. So I'm curious to see if it works, right?
So in downtown Sacramento, they don't have a mobile
They don't have
crisis
mobile
team,
crisis.
no.
The downtown
no.
Sacramento is Sacramento City Police Department, not the sheriff's office.
So,
Right.
so,
Yeah.
so every county has a mobile crisis team they're required to have a mobile crisis team for Medi-Cal beneficiaries.
Right.
I see
Wow.
bunny ears.
Yeah.
I am confident that Sacramento County has a mobile crisis response team.
They probably have one outskirts from what I was told, but in terms of downtown area, the G Street and all of that area down there, no, is what they said. So I
I'm
don't know.
reluctant to speak on behalf of the Sacramento County
Yeah.
Behavioral Health Director, but I would be pretty confident that they've got something, right? But I see him at meetings and I'd be happy to
Yeah,
chat
we
him
can check
up,
on
you
that.
know,
Yeah, that would be nice. Because, she was found several times and they refused to do anything.
So they don't even forward the website. They don't even forward it.
They show up, but they don't do anything. Yeah, they do not, yeah, they don't do anything.
Yeah, I'm sorry. No, it's just like, what I guess meant to imply was that a lot of counties are shifting into the mobile crisis model, right? And then there's still a lot of gaps being worked out county by county. And then unfortunately, what's happening in some areas is that, like, the goal is to kind of have established 24/7 mobile crisis teams and have clinicians responding first, right? But then a lot of those, that crisis now system has not yet been built up. But then kind of like agencies are pulling back on having law enforcement respond, and what's happening is like there's a gap of like, well, mobile crisis is not filled out, and then law enforcement is kind of reluctant to kind of intervene, and then you have people not being served. So I think what you brought up is very important, like that kind of gap of, yeah, we do ideally want like 24/7 mobile crisis with clinicians responding, but in the absence of that, we need to continue to kind of do like training law enforcement and have effective response in that regard.
It also
But that's
sounds
what I
like they
meant.
need to talk to each other.
I was just gonna say, like, we're sister counties, you know, it would be nice to link up.
Yeah.
I was thinking like Sacramento's sort of like our big sister, right? They're like 7 times as large as us, you know, it's already, every now and then when I'm in conversations with the child welfare director or the behavioral health director, you know, it's like kind of how do we partner effectively? But I'm happy to have that conversation and to get a better idea about what they're doing in terms of how their teams are operating and where they may have some gaps that they are aware of. I mean, I know that we have gaps, right, that we're actively working to address, and part of the gaps are really just making sure that all of the different partners we have, so law enforcement, fire, right, the general public, that everybody knows how to access services when they need them, and kind of untangling like who should be involved and when, right? I think that one of the biggest gaps that I could potentially see maybe in Sacramento County that is similar to what we might have here is if law enforcement's not going to respond, then does anybody know who to call, right? If they're not, because typically people just call law enforcement, right? And so that's the big culture shift for the community, right? If it's like, well, who then am I supposed to call when someone needs help like this? But regardless, I'm happy to have that conversation.
Yeah.
Okay, so,
I want to, sorry.
I just want to make sure he's not dying.
I got a scratchy throat.
Yeah.
And I want to apologize if I threw someone's name out there, I probably shouldn't have,
Oh,
just
no,
in
I
a
don't-
private conversation, I should have asked him before I made the comment.
Well, first of all, I'm super sorry about your daughter, and I'm happy to hear that she's in important care. So great. Yeah. I think though you bring up a great point, whether for Yolo County, I mean, because if we get to that point, you know, we're talking about, what we hear is we want law enforcement not to be front and center for a lot of these calls. We really want mobile crisis units to be there. So what can we learn from this as a county as we roll this out? Where are the gaps, and how do we ensure as this committee that we understand and what you just addressed, that we can address in Yolo County where our community knows who to call? Because we've just identified some gaps that potentially can happen, and just how do we know they're not gonna happen with us?
And these are issues I kind of addressed in the public comment I made to the UC City County joint meeting, where like this kind of duality has to happen, where we focus on building a mobile crisis. We have a 24/7 response. We make it easily like identifiable and like contactable by the general public, right? So we need to have that. But on the other hand, there are a lot of emergency calls that don't just exclusively have a mental health component, or might occur off hours, or might occur when the mobile crisis team is tied up, right? So functionally, first responders are going to be responding to mental health calls in this community and in other
Yeah, they
communities.
just can't say no.
Yeah, so the thing is, they also need to be trained and made aware of kind of how to handle that. you know, so like both of these things kind of need to occur at once. So we have a kind of primary responder, but then we also are kind of like building up the alternative
So,
responder. We wanna make sure.
so to that end, we do provide CIT training to law enforcement locally, and that's been pretty well received by law enforcement, and by all of the different law enforcement agencies who have really been on board with that. Also, conversations I've had with Chief Strange recently is that they are fully on board with supporting this model however they can. And we've had some conversations, some informal conversations also with at least one local fire chief who has indicated some interest in having their fire personnel trained as well, right? So there's definitely a lot of local interest in providing support around this issue and making sure that people are properly trained to respond to situations appropriately. But I think that the biggest piece around identifying gaps is ensuring that there's this coordination and knowledge sharing around, okay, how do we access services and how do we handle specific types of situations? So for example, if it's someone in the public and they need help, who do they call? If it's a first responder who's out on a scene, how do they get assistance, right? And then how can they potentially, like for example, paramedics or members of the fire department, can they actually participate, right? Because that's not something that's specifically prohibited. Like law enforcement is like not supposed to be one of the responders in the crisis model.
But shouldn't a lot of this be happening at dispatch? That's where I'm getting puzzled.
So I
So
mean,
for
wait,
me, my incident, I was told, I follow a process of what I was told. So that's how it played out for me. It could have played out differently for somebody else.
So there-
Oh, yeah, but I'm just saying, when you call 911, shouldn't the person who answers the phone know what it's
Dispatchers?
issue?
So
Exactly.
there's 3 local dispatch, if you count UC Davis, right? You know, so there's 3 local dispatch centers. We also have a call center. And there's some complexities that we've encountered in trying to negotiate how that should work, right? You know, first responders, they kind of have a way they want to call their dispatch and kind of have things go a certain way. And we've had better success with one dispatch than another dispatch, and we'll leave the names out of it for right now. And just also with the general public, it's coming through our hotline, right? So we're still working to sort some of this stuff out currently.
I think we had this conversation a year or so back when we were talking about CIT training and who should get the CIT training. I think they even talked about librarians, being that they're in a public domain, and sometimes, there could be a first responder. Because we have a lot of people who come in from off the streets, and before the police could even get there, if you have a librarian inside there, she's trained in CIT training to help to de-escalate the situation before help arrives. That might not even be a bad idea too. Who do we train in CIT? Is it just police and fire? Or do we add a few other components in there to get trained up on that too? Because it is helpful. I know. We've also evolved into co-responders where we have the CIT and then we have co-responders that go inside there. At first, I think it was with the police department, but we don't want the police department to be inside it because you can trigger the people that are inside that are having the problem. So we want them to be there on hand just in case something happens, but not seen, to make sure that it's safe for our co-responders.
I think
Before
you're doing
they
a great
leave.
job, John, of articulating the multiple factors that are, have to be considered for that, right? And the CIT training is so effective and so helpful. And there's also other kinds of training too that might be even more beneficial for somebody at the library, such as our mental health first aid training, for example. And it's really encouraging to hear that our fire partners are interested in also becoming CIT trained. And it's really part of that larger comprehensive crisis continuum of care that we've been talking about here for the last year and a half, and continuing to build with the complexities that there are, being that we're a county with 4 different official cities and different jurisdictions and different ways of operating and making that all work, so.
And I guess like something to piggyback of what you were saying about like CIT training. So as someone that's worked in fire and worked in EMS, the amount of training and awareness there is towards mental health is absolutely like abysmal. Like, it is worse than for the police department, like, the police, I think, at least get more training during their academy regarding mental health, but with fire or EMS, it is a 2-hour lecture at EMT school, and that is absolutely not sufficient, especially when you look at like the prevalence of mental health calls and how a lot of unrelated, like, calls that aren't initially labeled as mental health have a mental health component. And I think there was a recent estimate, like about like 20% of calls have like a substance use or mental health component, you know, across like 8 different cities. And I don't have the stats for this area, right, because that's not publicly available. But then the thing is, if this is happening, it kind of needs to be addressed.
So it sounds like you would agree with the idea too of bringing that CIT training to our law enforcement to our fire partners
Yes,
and to our EMTs. Absolutely.
Definitely.
Can I just ask, how often do we do those trainings? Are they annual or?
That you mentioned that it's 2-hour long it's a course in the academy, right?
It was at EMT school.
That's all it is, but then what we have for the county is longer than that, because I think it's a week-long training that we have.
We offer 40-hour trainings and then 8-hour refreshers. And Melanie, to your question, it varies throughout the year depending on staff availability, but we try to do it quarterly, at least twice a year, where we provide a 40-hour training and then we do a couple of 8-hour refresher
That's pretty
courses.
good.
And we also had a pretty good response lately with our police department getting everybody trained up, whereas before we had a slow start. But now we have a much better. And again, like you said, you have the refresher courses too, they keep on to the training.
Yeah, and what I wanted to emphasize is with CIT training, the importance is not just with the content of the training, like this is what bipolar disorder is, this is what schizophrenia is, this is like how the systems work. But I think there's a lot of importance in teaching like attitude, right? Or like humanizing the people that they're responding to, because then towards mental health, there is still an enormous amount of stigma. And then these people are very vulnerable and othered by society in general, and then especially by kind of more like traditional agencies that want to kind of like treat it as like separate class of people, right? So I think it's very important in the training to humanize people that are living through mental health conditions and like really emphasize like they need to have a compassionate response instead of kind of criminalizing this.
At one point, I wanted to go in myself and do an audit of the training to be able to go and see what it exists, what it persists of, you know, and then I never did get an opportunity to do that. But I think it would probably not be such a bad idea if the people such as ourselves were being able to go inside there and get a little bit more information on what it pertains. Also, educating the public, or, you know, I mean, you can't make them go to classes, but you can give them a link, because it's been brought out more and more in conversation, CIT training. What is it? Well, to give them something so that they can go to, that's easy enough for them to understand, because I know when we first started talking about this, I went online and researched a little bit about CIT and what it consists of, where it started at. And I thought it was pretty helpful. So we might think about maybe doing that too, making it available.
So we would welcome you if you wanted to come and, you know, audit the training. I don't think that would be problematic, right? If we could make arrangements for you to participate, if that's something, I mean, it's a pretty significant commitment for the whole week, right? You know, you're in 8 hours a day for 5 days a week, right? But if that's something you're interested in, please let us know. I will say that, you know, to your point, and I'm not going to pretend to know to what degree fire personnel get trained on behavioral health issues, right? But it is encouraging that we do have, you know, at least one fire chief who is approaching us and saying, hey, we would be interested in having our staff trained, and even having co-responders be with fire instead of police, if that would make more sense, right? You know, and again, I'm not saying that is or isn't the way things should go, right? But it's very encouraging that we do have fire who is saying, hey, we do want to be a little bit more involved in this, and we want to make sure that our staff are trained as well.
Maureen, we have the long-range planning around here.
We have a
So-
lot today.
Yeah, so one of the things what I'm hearing is, compared to last year, like we had a lot of questions, and this year what I'm hearing is that we're kind of looking at putting the pieces together, and what does that look like, and then what would that work look like for us, and how do we support it maybe? And so maybe this is something we could
put it that
put
section.
on the ramp calendar and maybe, not to put somebody on the spot, but maybe one of the things is for her to share her, presentation maybe at some point too.
That's a good
Yeah,
idea.
I'd be happy to do that, because for that public comment that I made, that was 3 assignments I did for school matched together, and one of those was a presentation, so I'd be happy to kind of give a professional and consumer perspective on how the system works, because I'd say I'm fairly familiar.
I wanna hear it, I wouldn't mind hearing it.
Well, I
Instead of
think,
reading it,
you know,
reading
we
about
have-
it. And then now that your experience, I mean, I think we have a really good opportunity here to maybe this year kind of look at things a little bit differently, because we're progressing, which is great, so thank you.
Yeah.
Thank you. But my point, what I was really trying to say is that Yolo County really is the bomb as opposed to Sac County. I'm saying that publicly.
Oh, we heard
because
that.
Yeah, I just wanted to.
Nice job, Tim.
Yeah.
That is great.
We're gonna hear that, what's not
That is
working?
greatly appreciated.
Yeah,
Believe me, I always say what's not working, so you know what, we have to come back and we have to also talk about what is working, you know.
No, we appreciate that.
It is greatly appreciated, and we are happy to bring that message back to our staff that the local behavioral health board is recognizing.
I want to express really, sorry.
I'm sorry, go ahead.
Yeah, and I want to express really, I didn't mean to be sarcastic, it just was just like expressing.
We won't even give a minute for trying to like appreciate what you do, right? We're just. To Melis's point, like, where are we gonna say, like?
That's perfectly fine.
So there is a lot in this packet, so I'm gonna move us along. Jonathan is not here this evening to give a report, but I do want to call out that we do have 2 vacancies. One in District 4, and then Joe Galvin has submitted his resignation from the board, so there'll be an opening in District 1
Who's also in District 5?
and in District 5, so we've got 3 actually. So, you know, I know that Supervisor Villegas may have identified someone to, for that seat, but we still have 4 and 5, and so something to consider for future.
Required to get a consumer for substance use disorder as one of those slots.
Yes, and that's being addressed.
Okay.
Yeah. At least in District 1. So,
Sorry,
go ahead.
I just had a question. Could another one of those be other student or young adult representative?
Where are we at with our counts? I think we have to
We
take.
have a max on young adults.
No, no. I just mean, are we,
Extra ones.
no, I meant in terms of are we missing
I think we just
anything?
need a consumer. I
Okay,
think that's the only thing. we're missing.
okay.
We,
So then-
we can overachieve, I guess.
Yes, I just meant, are we achieving what we
Sorry.
need to, the minimums? And I didn't articulate that well, so, but yes, potentially, that would be great. Okay, next item, correspondence. Do we have any correspondence other than what's being submitted tonight? Okay. So then we're gonna move on to the mental health director's report. Did anyone have sections that they wanted to pull?
Just before we get it, I just want to apologize for getting it out so late again this time. There's been a lot going on, and I'm definitely committed to trying to get it out as far in advance as I possibly can next time, but I apologize that it just came to you today.
So Maria, and,
Yeah, I think, which one?
B is in boy,
So B
F,
and F
and G.
and G. And then maybe Tony, just a high level of A.
Did you say B, F, and G?
Yeah,
Okay.
just a high level of A for those who might not.
Okay.
I guess that's,
I,
according to the year, you don't want to.
any others? Those have captured mine, so anyone? Okay,
Okay. Item A here is about the leadership transition and health and human services in our county administration office. So, as you all know, Carlene Jakowski left the agency in January 17th of 2025, is now currently employed at the California Mental Health Services Authority. Last week, it was announced that our agency director, Nolan Sullivan, is also departing the agency. So he'll be leaving at the end of the month. March 28th is his last day. He's going to Sonoma County, and we are still, he's still working with our county administrator's office and our board of supervisors to develop a transition plan. We've been receiving support for the last few months from the former HHSA director, Joan Flannel, who's actually on the call.
Hello, Joan.
Thank you, Joan, for being here. And so she's been providing some additional support to executive leadership in Carlene's absence, and so it hasn't quite been determined yet, but we also have Joan as a support as well. And so as soon as we have an update on what the actual transition plan will be, we'll make sure to let you all know. I just want to make sure that this is on your radar, that we have some leadership changes that are happening within the agency. Additionally, I'm not sure to what extent you were all aware, but we had an interim CAO as well. And so the board has selected Mike Webb as the new county administrator. So he was appointed on February 25th. His first day is going to be March 31. So coming into April, there potentially will be a whole new leadership structure. So we'll have a new CAO. We will have to have someone who's in the role as the agency director and interim director. Just want to make sure you are all aware of that.
Okay.
I'm not going anywhere.
You're not allowed.
I have no plans to go
Okay,
anywhere.
yeah.
I just got back.
It's recorded, don't forget.
Uh,
It's a good contract. Okay, thank you for sharing that.
Yeah.
I know that must be stressful.
I think that there's a little bit of anxiety with our staff, right? Because these kind of changes can feel like, okay, what's happening? And then, of course, there's a little bit of, there's some concern that comes up, like, for example, my own staff are like, are you going to go, or are you going to do something different? Like, what's going to happen next, right? But I don't, I'm very happy for both Carlene and Nolan. In talking to both of them, this seemed like it was the right thing for both of them to do. And I do feel like we have a strong leadership team that can navigate this. It will definitely be challenging, but I also don't think that there's anyone that's part of the leadership team that's like panicking or that is feeling like this is insurmountable, right? It is a big loss. I mean, don't get me wrong, right? But at the same time, I think that this is something that we can successfully navigate.
Thank you for sharing.
Yeah. So item B is around behavioral health staffing, and I wanted to include this just because we're entering this phase right now, and you've heard me talking about how we're having contracting budgets, and we're entering a really challenging budget cycle currently. We have a hiring freeze, and it's been a little bit on again, off again. Like we've had a freeze in place, and we've had permission to move forward on some positions, and it freezes back up. And during this time, we still have some capacity issues internally with our staffing, right? And so I just want to make sure, just as the local behavioral health board, that you guys are aware of where some of these challenges currently are and how they might impact what we do as a system moving forward, right? So for example, we're having some conversations about how we can adequately support the Davis Clinic. As you know, there were some budgeting challenges that happened last year with our Mental Health Services Act budget, and it required us to terminate a contract for the Davis Clinic that was supporting that site, and we're struggling to staff up that site right now, and so we're in the process, it's on the board, next week, right? To make some decisions about how to move forward with the Davis Clinic. And so I just, more than anything else, this is around transparency for the board to just kind of have a better idea about where we may have some staffing challenges. And we'll try to give you a little bit more information around FTEs that we do have in specific programs, if that's something you're interested in. But I just want to make sure that it's something that's on your radar, that we do have some vacancies that we're struggling to fill, in part because everybody in California is competing for mental health professionals, and in part because of our budget circumstances and our hiring freeze.
Question, when it says, 2 clinicians are not in this total, does this mean they were ads and not like in your run rate?
What it means is that we have 3 vacant clinicians, so we have 3 vacant clinicians positions, but we were also seeking to add 2 additional, clinicians for the Davis Clinic, but we were not able to get that approved.
So the ads weren't approved?
Yeah, so
But
they're
there were
not,
no cuts?
they're not part of the 3 FTE. No, there's no cuts.
No cuts, just not, the new positions are
Right,
not approved?
Right, yeah.
Okay. And then I know we talked about this, and this is kind of also in G, the grant, the limited term position. I'm just curious, and I apologize if you already shared this. Is this like a matching grant that we got? Like we have to pony up some dollars for the,
No, the Child Youth Behavioral Health Initiative was not a grant where we were required to provide matching funds. So this is just money to implement the pilot project. But the challenge that we're having is that because the county is in this contracting budget cycle, that there is a reluctance to create limited term positions currently.
okay, so we got grant money, right? But we aren't going to use it?
Well, so we are going to use it, right? We're just not going to.
And
we're
I
not-
don't visit you. I'm
Yeah,
just
no, that's
trying to
okay.
figure
That's
out-
all right. I mean, that's okay. So we are not going to be able to use it in the way that we initially proposed to use it, right? So we're working to find a solution where we may be able to use existing staff, right? But we're still working out the details.
Because it would be a shame to not be able to use the
We,
grant money.
well, of course we want to use grant funding when we went through the process of competing for them and having them approved. And we have every intention of expending them.
So Maria,
I was just gonna ask though, part of like not using it in the way intended, is that because you foresee you're not going to have money to sustain the positions or?
No, so, well, I mean, I think that's always a challenge with a grant, right? The
But that's
challenge
why
with
it's limited
the
term.
challenge with the
Yeah.
grant is, first of all, getting everything approved and trying to spend the money, right? That's always a big challenge. And then the other part is like, can you sustain what you're trying to do, right? And the goal with this particular project was to determine whether or not this is a service that was beneficial or even needed, right? Or to what degree it is needed. We know it's needed, but it's just like to what degree, and then is there potential for the physician to sustain itself through Medi-Cal billing or something like that, right? And the other challenge is when you are creating positions with grants, they tend to be limited term, right? You can't have the position go beyond the funding that's sustained, right?
Right.
And
that's
so.
not uncommon. That's not uncommon.
Right.
No, that's not
Right.
uncommon,
I
right,
mean,
yeah.
that's pretty much,
So-
yeah.
So when we say we're not able to implement the project in the way that we intended, we intended to have a limited term position. We just couldn't get it approved.
Okay.
So I guess I'm wondering if there's anything that this board can do
Yeah.
to try to, and I don't know, Maria, I'm gonna look to you because I don't know.
I'm
Like a
reluctant, I'm
letter.
reluctant to comment on that.
Understood, that's okay.
Okay. Oh,
Okay.
sorry.
I don't know what we can,
Would it help for us to do anything, or are you just thinking that?
it'll work itself out in a short time here or.
Should we give you space to come up with a plan before we get involved?
So we have a tentative plan that we were talking about just as of today. We have a tentative plan that we were discussing internally. And so I don't necessarily I'm not seeking you guys to take any kind of action or anything like that, let me put it that way. Right? It's just it's more about transparency. You know, we've come to you over the last few months, said, hey, we have this project, we're in the process of trying to stand it up, and we hit a snag, right? And I want you to be aware of it.
Can we ask then that this agenda item be on the next agenda item?
Yeah,
for
absolutely.
navigate?
Yeah, a lot of these are items that we're coming back to anyways.
Okay.
I mean,
Can I give you guys an example? In my school district, my superintendent applied for a grant through CYPHI, and my position is actually funded through CYPHI. That's only for 2 years. But within the process of application until actually making it happen, a lot has changed. And so the grants definitely require progress reports, implementation plans, and
Right.
you can just imagine. So my position has actually shifted so much, but it still serves a purpose,
Right.
is to provide mental health services for students and also awareness for staff. So I can feel that Tony's because the grant, I mean, my position is only 2 years. So what am I gonna do after that? I think the key word, like you said, is sustainability.
Mhm.
So we pray to the gods that
right, no,
I'll be in my district after 2 years.
I understand that. I think, any grant that I've ever applied for and student, we knew that that was the case.
Yeah,
A lot of
yeah,
times
and we-
grants
we
are
also knew that.
available, right?
Right.
Yeah.
And I appreciate your transparency, and I certainly don't want to overstep our bounds. I mean, if you've got it, I'm also concerned that we've heard how extended many of our county employees in this year are. And so I have no doubt you guys can be creative and figure it out. The question is, how much is that gonna overtax others? Or is that gonna take people away from other work? And I know you know your business, and I'm not asking you to tell me
No,
that, but it's a
absolutely.
concern that I have,
I-
when we have grant funding and we applied for a grant. And so, and I feel like it's being attached to, we have a hiring freeze. So I just, as a committee member, I just feel like I have to push back a little bit, not to you, but just to say, we
Understood.
really need to keep this on the forefront.
Yeah, no, 100% understood. And again, I just want to be clear that part of this is I feel like the behavioral board should have a understanding about where we are in terms of staffing and where we are in terms of projects that we've already, come out publicly to discuss, right? And I want you to have the information. I'm just reluctant to tell you what to do with that information.
Understood.
Okay.
Understood. But I think it's great. We'll keep an eye on this. But I just remember talking about this last time. We were all very passionate about it. We were excited
I
about it.
remember.
And
Yes.
so unfortunately, I remember things that, and so I was really excited about this too. So
It is
I would-
unfortunate
yeah,
to
it is
remember things
unfortunate.
sometimes.
I know, it happens. So
But we're gonna keep it on,
Okay, all right.
and then we'll figure out if we
we need something. Yeah, we don't want to overstep.
Okay.
So move forward back to F.
Okay, so we had our second round of interviews for the Health and Human Services clinical manager position who would oversee our crisis continuum on February 21st, and the recruitment did not yield a candidate for the position, so we intend to repost the position for recruitment as soon as possible.
Sorry.
And maybe this is a question on the long range planning, but I'm curious about this role. I know we're all really excited about this role as well.
I know.
And there has to be the right person out there, and I can appreciate that. I'm curious though, if this person would also be somebody that could help us kind of coordinate the whole life cycle of what we were talking about earlier, or if that would not be in the scope of this role.
When you say
Life cycle.
the life cycle of,
So just, we were talking about, there's all these, if we want to move away from a police, like we want this whole continuum where crisis now and crisis, mobile crisis, and all of these services are really coming together. Or is this really focused on getting crisis now?
My understanding of the position, right, and I think the vision for the position would be, they would handle all things crisis.
Okay.
Right, so all things crisis, so, all aspects of the Crisis Now project, starting with the access and crisis line, working through with responders, and, you know, potentially discharge planning, right? You know, but basically any of the crisis elements, interacting with system partners, like really kind of interacting with potentially elected officials, depending on whatever's necessary with that, right? But basically they would be over sort of the entire, local crisis system of care.
Adult and child?
It's a lot more.
Adult and child?
They would definitely need to coordinate with the child, so that part's always a little bit challenging when we talk about internally, because, you know, Sam's the adult director and I'm the child director.
And you guys don't
And so it's just
know.
like, and so it's kind of like, I guess, right, you know?
Right.
But they would probably, you know, I think that I would see it mostly, I would see it probably initially being mostly focused on the adult system of care because there's so much that's going on there, but like, I think that it would make sense for them to also have the children's crisis stuff fold up underneath them as well. Part of the challenge is like some of the stuff we're doing for children's crisis is like this school-based crisis continuum, and it's folding into another project, like the K-12 school partnership, right? And so it's kind of like, how do you kind of untangle some of that, you know, put that under a specific person, but they would definitely, at the very least, need to be coordinating.
Well, especially because the 13 and older is considered an adult for a lot of intensive things, and but they're still children, so I don't know where that cutoff would be 18 for this, or if it would be 13 like it is with kind of hospitals
And then with the state, sometimes it's 21.
Correct, yeah, and CCS has a whole nother, so yeah. So yeah, it'd be interesting.
But I think ideally it would be, and again, I don't know if it's my decision to push the vision, because I mean, the word interim is before mental health director here, right? But I think personally, I think that crisis is sort of this unique role, and that it would make sense to have the whole crisis continuum under that person, and then that team would coordinate with the children's team for youth that are appropriate for that kid, and that the crisis would sort of live in its own space.
Did we have a pretty good pool?
Mhm.
Did we have a pretty good pool of candidates?
We had a really small pool of candidates this time, and so, I do think we had good candidates. It just, the recruitment did not yield a candidate. I don't know if that's the right way to say that.
The right fit wasn't there.
We did not hire anyone.
I won't-
I think that's the most, I think that is the most diplomatic way I can say it.
Yeah, I understand.
Okay.
Do you have to have an agency director to hire this position, or will you be able to move forward with if there's not an interim?
Well, that's a good question, actually. I think it's really gonna depend on what the rules are when we get there, right? But I don't think that it's gonna be dependent on there being an agency director. And we have to have an agency director in one way,
Right.
shape, or form. I mean, there needs, whether it's an interim director, but there's so many different things that fall to the agency director that we really can't go without having an agency director. So there will be some sort of an interim plan, and that Nolan leaving shouldn't impact this.
Okay.
And something I just kind of wanted to emphasize regarding the crisis manager recruitment, like, and I'm probably gonna reiterate what everyone's already thinking, right? But the attitude, the approach, and the understanding that this person has about the current system and where it's gonna move is gonna be absolutely essential, because we're still building this, right? And like kind of trying to connect all the different components, and I'm like, I really hope that whoever is selected really kind of has that first, like compassionate approach, instead of kind of like a more like top-down approach to kind of like integrating all of these services.
What, could you expand upon that a little bit?
I guess the current emergency mental health system is very, or can be very punitive, and like the movement towards mobile crisis is a move away from that. I really hope like the attitude at every level of the new system is going to reflect a kind of more compassionate, more effective, more kind of like all-encompassing approach instead of like, we just drop a person off at the ER and we're done kind of thing.
I sincerely hope that that is not the impression that the community is getting about what we're doing right now.
No. That's not what I'm saying. The community is moving in a
Okay,
great
all right, okay,
direction.
all right, yeah.
But
Because I 100% agree with you, right? You know, that definitely, we definitely want someone in this position who is thinking about it that way as well, right? But I feel like we've made a lot of, there has been great leadership with our crisis continuum of care. And I do think that we are more than heading in the right direction. I think that we're making pretty great strides.
yeah, like the changes that have been made in the last couple of years of like even having co-responders at all, and then kind of like expanding the hours, hiring more people, like changing the way that crisis is responded to, like I think those changes are like both like better from a consumer perspective, like in terms of experience, and also like more effective overall. But like I know kind of like a lot of times these changes can be really like fragile, right? And so like I hope we continue kind of moving in this direction.
Do we have a
Yeah.
consumer on the interview panel?
We did not this time, but
Oh, sorry.
Should I not have asked?
She's thinking
so I think that there is a challenge. I think that there can be a challenge locally with including a consumer on a panel because we'll tend to have internal staff who apply, right? And so you get into this kind of a weird conflict where this is someone who may have provided a service to someone, and then now they're making a decision about whether or not to hire someone. So I'm definitely always open to having consumers and people with lived experience participating, right? But I want to be, I do want to be careful about that potential dynamic that could happen.
Yeah, and I want to say from a consumer perspective, I think what you said is important, like it's very important to prevent like conflict of interest, but then I think that the point is also like that consumers are able to give input at some point in the process, and then exactly where that point is matters less than the input overall, if that makes sense.
Yeah.
Yeah.
I mean, we did have a member from the local, we had a member from the board who did participate. So, but yeah,
So I'm a little bit of a consumer, I guess, right?
Yeah, I would think we'd be the voice of the consumer in some ways.
Yeah,
Mhm.
yeah.
I trust you.
Yeah.
But it's still like family perspective is very different than consumer perspective, and I think it's very important to have kind of both when kind of making like policy decisions or deciding where to move forward. But yeah, just as long as like consumer input is considered at some point in these systems and processes, that's kind of the important thing, rather than where specifically that input happens, if that makes sense.
Understood.
Would it be fair to say that you probably aren't gonna have an internal candidate for the re-recruitment?
No, I would not say that.
I would assume that an internal would have.
Yeah,
Just a second.
I would just say that I would not count out internal candidates.
Okay.
Sometimes people change their mind, they think about it, then they hire.
Sometimes,
Things
some-
happen, yeah.
Yeah.
But, right, you don't wanna count that out, I can.
100%.
That's not.
So I think we talked about G. Were there any other questions about G?
No, I'm.
Okay, so
Okay, well, that brings us to everybody's favorite topic, Proposition 36. We had a lot of back and forth around Prop 36. And we had agreed initially to take on 3 clients just sort of as a pilot to kind of figure out how to make it work. And then meanwhile, there was sort of a separate conversation that had happened that had arrived at a separate solution. And there were many side conversations that were happening that were starting to kind of muddy the water, right? And so, was it last week?
Yes,
Yes,
it
it was
was.
last-
It
it was
was
last
last week.
It's hard
It
to
was the end of
tell.
last week.
Last week, we got together with, Samantha and I got together with the district attorney's office, the probation department, and King Carroll Lay, and we have a tentative plan now. So essentially, what we're looking at is that, all in-custody referrals would be routed to King Carroll Lay to, provide an in-custody assessment, through an existing contract to provide in-custody treatment services. Out of custody, individuals who have Medi-Cal, will be routed, all the defendants will get referred to probation, right? Probation's agreed to sort of take on essentially the case management aspect of Prop 36, right? And ensuring that clients get routed to treatment and reporting to the court, right? So out of custody, defendants who have Medi-Cal will be routed to community care.
That's Yolo County residents.
Yes, Yolo County.
That's just, 'cause
Not, if somebody was arrested here, but.
we have a
was
lot of people
resident.
from out of county that get arrested.
We'll be working through all of that too, right? Yeah. So there's all kinds of wrinkles, as you know, right? So it's like out of county residents who are defendants in our courts, individuals who have private insurance, right? And then, the treatment aspect of it, right? So where we're kind of at a preliminary stage right now is that we do have an existing program for in custody inmates to receive treatment and to receive assessment and treatment. And so we can leverage that existing resource. We already have treatment for any Medi-Cal beneficiary from Yolo County, right, to receive treatment. And we'll leverage that as a resource. And some of this really is, and I hate to say it this way, but I mean, I feel like we're in a little bit of we'll cross this bridge when we get to a territory around some of the other parts, right? So the tentative plan really is for an individual who has private insurance, right? As a probation will kind of help them navigate their private insurance to get an assessment and recommendations for treatment and report that information back to the court, right? And for out-of-county defendants, I'm not 100% sure how we're going to do all that, right? So we're bringing some of this forward to CCP to make a request for funding, right? Because we are already anticipating, I mean, there's no funding attached to this in the first place, right? And so any services that a Medi-Cal beneficiary would already be eligible for, we can provide those services, right? But outside of that, funding is going to be a pretty significant challenge, especially if we end up in a situation with like an out-of-county defendant or an individual with private insurance, and the recommendation is for residential substance use treatment, one of which can be very expensive. The Prop 36 says the defendants can't be charged for any of the services. So some of this is still, there's flying the plane while you build it, I think, is one way of putting it, right? And really,
I'm assuming most private insurances have a copay for the residential.
I'm really reluctant to even talk about private insurance because I think that it's, there is a lot of assumptions that like you could even get an assessment that, that would comply with what is required under the statute, and that
I think it's safe to say that we're committed to figuring it out. and that
Yes.
There are so many scenarios that could present themselves that we haven't been able to fully predict and figure out a path forward. We figured out a path forward for the most common, what we expect to happen. And we're committed to continuing, on a case-by-case basis if we need to figure out, okay, how are we gonna get through this one now? We're gonna make sure that people's needs are met.
Okay, so I'm gonna go back, this is sort of the question I asked last month, but I'm gonna ask it a little differently this time. If somebody is charged at the higher level in order to nudge them into treatment, are we committed to making that treatment available to them?
I think the quick answer would probably maybe, because if they have private insurance, there's no funding mechanism for it right now.
But
It
if
might be.
we're going to charge them at the higher level, I mean, there's an option there too. They can not be charged at the higher level if we can't treat them.
The charging decision will be made based on the police reports, and they're not gonna have someone's insurance information when they're doing that.
Okay,
My
so we
understanding
might-
is that 30 people have been charged under this new statute, and only 6 have been interested in treatment.
So all I can say about this is that you have multiple parties that are part of the conversation. So you have the district attorney's office, you have probation, and us are sort of the 3 primary players, right? And everybody has different responsibilities, right? And there's some pieces here where there are some overlap on responsibilities that make sense. And there's some areas of this legislation where there's a responsibility that's sort of out here that really doesn't fall to anyone. And so the question you're asking, it's like, if we're gonna charge a defendant at this higher class in order to sort of, quote unquote, nudge them into treatment, are we really gonna be committed to providing them the treatment? From the mental health plan's perspective, it's like, if that's a Medi-Cal beneficiary and that's a service to which that person would already be entitled to, of course we would, right?
Yeah, that's not really what I'm asking.
But which is why I phrased it the
I-
way I did, right? Right, but so if this is a person that the mental health plan is not responsible for, I'm very reluctant to take on that responsibility as the mental health plan, because every time the mental health plan takes on that kind of responsibility, then that detracts from our ability to provide the service to the individuals to who we are actually responsible for. And that's really the most challenging aspect of this legislation, because we could potentially end up in a scenario like you're describing, where there is an individual who has a significant need for very expensive treatment. And if the mental health plan agrees to take it on and sort of sets a precedent that we're going to do that, it could be very costly. And it could impact our ability to provide services to individuals with severe mental illness, right? That are our core responsibility, right? And so I don't want to come across as being uncooperative. I think I told you all, second week on the job, I don't want to start off by getting into it with an elected official, right? Over legislation that he authored, right? But at the same time, my responsibility is to the mental health plan, right? My responsibility is to Medi-Cal beneficiaries who have serious mental illness in Yolo County, right? And so I can't commit to that. I can commit to trying to find a way, right?
Is there any kind of mechanism to sort of go back and say, look, we can't give them the treatment, there's nowhere they can get the treatment, so don't change the charging?
I think Chris, I'm gonna have to phone a friend.
That would be a conversation that would be brought to the courts, that person wants treatment, they can't get treatment for whatever funding reason. There may be a difference between, say they get assessed by a community care clinician at a certain level of care, but they're have private insurance and they want to try a lower level of care before. And we've had this issue where we refer people who have mental health issues to get assessed by the county for what level of care they're gonna get through the county. And sometimes the county comes at a level of care that the attorneys don't always agree with.
Yeah.
And so that you're gonna have that challenge with the addiction issue also, I think with Prop 36. And the key components, I would think, would be first to get that assessment as to what level of care, and then try and navigate the systems. We do some of our other diversion programs. We have a case manager, clinician that does the assessment, and then if they're not a Yolo County resident, try and get them into treatment, either their private pay, through the VA, or through Medi-Cal. If they're in another state, try to get them engaged in treatment that way with what they have available. And that can be very time consuming and challenging, because you're navigating all sorts of different systems. Each county is kind of like their own little, even for Medi-Cal, a little silo, how they entry points that require navigation.
Right.
So it's very challenging.
So it sounds like it would be on the defense attorney to say, this isn't fair, this isn't going to
Well,
work.
but the public defender's office also has a number of social workers that can help navigate, their clients navigate that, and they do that for other types of programs. The mental health diversion, the statutory one, I quite often put in case plans together for their clients with the treatment proposals that the court would then approve. So that's a possibility here too.
I will just the only comment I'll make to that is, to the best of my knowledge, I don't know to what degree the public defender's office has been engaged in this conversation, right? And so the working proposal for this initial implementation is that probation would take on some of those responsibilities that you're saying that the public defenders, social workers could potentially do.
It might be that there's CCP funding for like a clinician or case manager to the management part.
I will say that we are committed to working with the district attorney's office to find a solution, and we're definitely committed to seeking out funding that could help to kind of cover those gaps. But then I think we kind of get into the grant funding or whatever conversation as well. I'm reluctant to speak to some of the other proposed ideas that are out there, but essentially there are some existing structures for justice involved individuals locally that we might seek to, but they're not our contract, so I'm not going to talk about them. But there's some conversations about potentially pivoting some existing systems to capture to help to serve this population. You want to weigh in on anything on this?
Yeah, I think that I would just come back to, and not because I'm trying to divert, but because I really do believe that we're gonna encounter so many different cases and situations that we just don't have a playbook for, and so we're gonna figure it out as we go along. And as Tony said, and as I said earlier, we really are committed to making it work. And we're really good at finding solutions. When we don't have the answers to start with, we can figure it out. And ultimately, we're committed to helping people get the treatment that they need. And part of our commitment to the beneficiaries that we're charged with serving is making sure that those funds stay available to provide that service. And at the same time, as a social worker at heart, Tony's a social worker too, it's like, whatever it takes to help link people to the right level of care. And so while we can't speak for a commercial insurance company, we certainly do have ways to help advocate or connect people who can advocate toward that treatment, but we can't speak for whether or not it would be approved, right? So I wish I could give more fundamental, concrete answers. And I think it's brand new too, right? So I think your questions are great. What's gonna happen if somebody gets a higher charge and they're not able to get the treatment that they want? Then what's gonna happen? And I don't think we've seen that scenario yet either. So I'm not quite sure what'll happen with the attorney's offices and the charges and what'll happen there either. But I have faith that they're gonna figure it out too. Yeah.
Well, thank you.
You're absolutely welcome.
I always love it when you ask a question.
I'm not sure how to take that.
I do. You ask great questions. There is another, and I apologize, that there was one other thing that I would like to talk about that really should have been in the mental health director's report, but it was like we were working on it today. And there are a few interrelated points, and I'm going to just try to hit the highlights because I know we've got a lot going on, right?
Yeah.
But we have a situation where we have approximately $473,000 that is subject to reversion. $473,000 of Mental Health Service Act funding that is subject to reversion in July of this year if we don't have an approved innovation plan in place by June 30th. And we are proposing to submit an innovation plan to join the California Mental Health Services Authority semi-statewide electronic health record partnership. The county has been working closely with CalMesa to complete necessary documents to allow us to opt into their existing approved innovation plan. So basically, CalMesa has an approved innovation plan. They work with multiple counties around a pilot project that they have, which is an electronic health record, which will allow them to aggregate data, and they've already demonstrated this to the state, and we're requesting to opt in. So what we are looking to do is to opt into this, which will prevent us, would prevent us from reverting the funds. What we would anticipate, we're still working on the budget, we're anticipating that we would request about $1 million of the innovation funds over the course of 2 years to participate in the program. Just real quick, the semi-state EHR was designed for California behavioral health departments to support robust data collection, facilitate federal and state interoperability mandates, and to reduce documentation time, allowing clinical staff to allow them to provide more direct client care. It builds inefficiencies to alleviate workforce shortages and integrates talent payment reform changes that will additionally address upcoming behavioral health transformation and associated regulations. We've said this many times before, our behavioral health system has an operational deficit. It's in part because we don't receive general fund revenue the same way that other county behavioral health departments do. It's required us to rely more heavily on federal financial participation. That's funding that we draw down from Medi-Cal billing from the federal government. Our current EHR is antiquated, it's cumbersome, it's a lot. I don't know how else to say it than that. And it's created a lot of challenges for us with talent payment reform. And connected to this is that many of our, we've been unable to process a lot of our billing and we're way behind. And so that's creating a cash flow problem for the county and as we're trying to work through it. And it's also straining some of our relationships with with some of our vendors. And I don't want to get too far off this topic and I will come back to it, but one of the vendors that we are having some challenges with is our largest provider for FSP services. And we're very worried in that particular contract that we may have a problem on our hands on July 1 for FSP services. So that they're all of these things are integrated and interwoven. And I'm here presenting this to you on two different parts, right? One is to let you know that we intend to seek this as an innovation plan, in part because we think it's the right thing to do, and in part so we don't revert almost $500,000 of funding. There's a timeline that's associated with it that is going to be very rapid. And so we would intend to post the innovation plan publicly next Monday. The public, it would be a 30-day public comment period that would end on April 8th. We would want to take this to the Behavioral Health
Oversight and Accountability
Oversight and
Commission.
Accountability Commission at their April 24th meeting. To meet that target, we would be requesting to see if the Behavioral Health Board would be willing to have their meeting on April 9th instead of April 2nd. To service the public following the 30-day comment period, or to have a special public hearing after April 8th. And so that's the first part, is to say, hey, surprise, we're going to be doing this very rapidly so we don't lose $500,000. Secondly, we're having some challenge. Our existing system is creating some challenges with some of our contracted providers, including a very important provider. And we are just making sure that you're aware that we're navigating some pretty significant challenges with that particular relationship, but that we could find ourselves in a very tricky situation if we can't resolve some of the issues that we need to resolve.
So just so I'm clear, so the problem with the vendor is that we can't pay them because we haven't been able to bill?
The problem with this particular vendor is that it's a little bit more complicated than that, right? But there's just been some back and forth around the billing process that has, basically what they're saying is it's too cumbersome. It is creating a lot of administrative overhead for them. And there have just been some challenges between our agency and their fiscal department that are just unsatisfactory for them. Another piece of it, to be perfectly honest with you, is has to do with third-party billing, right? So when it's an individual who has insurance other than Medi-Cal, they're required to try to seek payment from the other. And so what they're saying is basically they've got a lot of money that's kind of hanging around out there because they're trying to seek it from the other insurance provider before they can bill us, right? So this is part, this whole billing issue is part of the challenge. And it's one of the things that we're seeking to correct with a different electronic health record, but it wouldn't be here Like, even if we get this innovations plan approved, like this new electronic health record wouldn't be here for a couple of years, right? It would take a while for everything to get moving forward. It's just illustrative of the kind of problems that we're having. We're having other challenges with this particular provider as well that I'm reluctant to get into just because of time, but I'm happy to bring this back to the next meeting as a specific item to get a little bit deeper into it. I just want to make sure that the board was aware of the fact that we do want to pursue these innovation funds, and that part of the reason is that we have an existing system that's creating challenges for us with some of our contracted providers.
Do we should vote on moving the meeting, or do we just?
I think we do.
Huh?
When we need to vote on
I'm
the
moving the
meeting.
meeting.
Oh, with that, yeah, well, I mean, I think that that's for you, yeah, sorry. But
Do we have any?
Discussion wise,
Discussion.
we should probably get scheduling, because we're looking at the 9th. Or if we want to do a special meeting for this purpose, I assume it's the other meeting's the 24th. So it has to be, we have to be between the end of the 30-day period, and whenever you have the other committee that's meeting.
And before that also, because we have to, in order to go before the Oversight and Accountability Commission, it has to be after the approval of the local behavioral health board.
Okay. You'd probably have to Brown Act that one for noticing it.
Brown
So we have
Act
to-
the,
We have about a week or two
Yeah.
to do this, right?
Wait, I'm confused.
so the sequencing is this: we have to post it for a 30-day public comment. Then after the 30-day public comment, we're required to have a meeting with the behavioral health board so that you can consider the public comment and give us additional feedback, right? And then we're supposed to carry all of that and adjust the proposal as necessary based on the on the commentary that we received. The EHSOAC also has to approve the plan, but they can't do it until after we've done that part.
And in their meetings,
And our board we're also gonna have to get it approved by our board of supervisors. We're on a very ambitious timeline.
but that meeting that they have, you said it's the 24th?
The 24th, yeah.
Okay, so we have to do it between,
But you already worked out that if we move April 2nd to April 9th, it works,
As
right?
long as it's after April 8th and before April 24th, I think we're okay.
Okay.
And-
So we're in a hole there, because we meet before then, and then we don't meet till later.
Right.
Exactly.
Yeah.
Exactly, sorry. Thank you for, that's
it's
the
okay.
issue.
so does anyone have a conflict with April 9th? It's probably the first question, right?
I don't know about the rules that are not here.
I understand.
I do not.
But we,
But I mean, I think, yeah, that would be the first question. Does anyone have a conflict? April 9th.
So we would move our meeting, and so would then you be giving a presentation at that time about this?
Yes,
Okay.
So we shouldn't
Then
schedule any
we-
other
then
presentations.
we
No.
don't have to. Okay.
So move our meeting,
Well, we need a motion.
I move to move the April 2nd meeting to April 9th.
I would second that.
All in favor?
Aye.
Any opposed? Any abstentions? Okay, we'll move the meeting we've approved moving the meeting from the 2nd to the 9th in April.
we're very grateful,
Thank you very much.
Just remind me.
Christina, when you're listening to these minutes, please let's remind John that we moved the meeting from April 2nd to April 9th.
And also please send a calendar invite changing the meeting.
Absolutely.
Those change for our website too.
You know, again, I apologize for literally the last minute. Some of this we're working out literally this morning.
Guys have a lot.
Yeah.
Will this program help the providers document the services at all?
Yes,
Yes,
yeah.
I've seen that's one
it
of
will
the
help
problems.
on so many levels.
Long term, it will help us to really provide some, the benefit for this board, I believe, is that you have all asked for data. And we have RBAs in place and that's great. But RBAs are not a very robust data set, right? You know, RBAs are data points. And then, but there's not a whole lot of opportunity for us to like really expand them or to do like multivariate analysis or anything like that, right? It's just we get data points. The vision would be that we would have all of our providers in the same electronic health record, and then we would be able to pull out data and really get a better understanding about what's happening locally, and then inform our decisions based on data that like we can really rely
And
upon.
this health record system would be used by multiple counties.
It's currently used by 30,
I was gonna say it's over 25,
I know.
30,
I want to
low
say,
30s.
I thought it was 32.
Is
Right.
it integrated or segregated by county?
It's segregated by county, right, yeah, so however, I keep saying that, and so I've been wanting this for a long time, right, before I was in any position that had interim and grip under the name, but like, on the child welfare side, we have the Child Welfare Services Case Management System, and it's an integrated system of all 58 counties use, and so the UC Berkeley through the California Child Welfare Indicators Project is able to extract data, and you're able to see how you're doing, right? And it makes case management very easy. So if we end up with a youth, and then for some reason the family moves to another county and the case needs to transfer to the other county, we just tell the other county, right? And then we do something in the system and they have everything. And I think that there is just this great opportunity for, it's called smart care, to have something like that in the future. I mean, imagine how much better that would be, right? Your daughter is in Sacramento County and they could maybe look at these records, right? You know,
Right.
Is Sacramento County one of the counties using this system?
Sacramento County is one of the counties.
Yes, it
right?
is.
Solana.
So right now there's firewalls, but right now there's firewalls.
I have the list of the counties here if you'd like. We have one of our colleagues on the phone who just looked it up, but everything from small counties the size of Calusa to large counties like Contra Costa and Sacramento,
San Diego.
San Diego.
Maybe
Yeah,
that could be part of the next meeting.
So if your contract provider has managed to do this in Sacramento County, that system.
Correct.
They'll be able to do it here much easier
correct.
and get the billing problem solved long term.
The other potential benefit to us as a system of care is that because so many counties are going to this system in the state and because they're requiring the providers to use it, the providers are all familiar with the system. And so we have a lot of like individual training that we have to do with providers that we take on to help them get into our electronic health record and to kind of get them up to speed with how it works, right? Where this is a health record that we're confident that many providers are going to be exposed to, and that it would just be a matter of being like, oh, we use that too, right? The other thing around this health record that is kind of not so great, right? But is sort of a feature, not a bug, is that it'll be the same for all counties, right? And it's kind of the same way I described Child Welfare Services Case Management System. It's the same for all the counties, right? So all of the data points are the same in every county, right? Where our health record that we currently have is like unique to Yolo County.
This is for both adults and children, right?
Yes.
All
Yeah,
the records.
the
Yeah,
entire
mental
system.
health and substance use.
So when you say it's segregated, so like on the acute side, there's something called Care Everywhere, which all the ERs then can look at everybody who's been in the ER. So is there something similar to this where if, somebody's in Solano and now they're here, that the provider would be able to see the care that was provided in another county?
That's more of a health information exchange, and that's like external to the electronic health record.
And I think that's a level of detail that we could get the
Yeah, I'd
answer
just be
to and then come
curious
back to you
if that-
about. I have some familiarity with it, but not to the level that I feel comfortable responding.
And then, not that I'm not supportive, I just think something to consider is that anytime, even if you make an upgrade, it potentially changes workflow for the providers.
Yeah.
And so one of the biggest
It will be a painful transition.
satisfiers electronic records, and you
Yeah.
probably know that, so just to be sensitive of that when you're.
Change
Rolling
fatigue
it
is
out.
real.
Yes.
Yes.
And so, otherwise, yeah, it's a thing.
It's a thing and we have lots of feelings about.
So it takes, there's a investment up front, and not just in training, but in our workflow's gonna change. This button's over here now instead of over here, this is over.
Mapping out process
Mapping out
flows,
process flows,
workflows.
all
If you
that
don't
stuff.
do that accurately, then you're
Correct.
gonna end up with
Yeah,
a problem.
say no more, yeah.
No, but you're speaking my language. My love language. Thank you.
Yeah, me too.
Okay. We have not done a second public comment, so I just wanted to do that now. Do you have any public comment?
I do not see anybody online with a hand raised or with a chat.
Okay. Then we will move, do we have anyone online from the Board of Supervisors office?
Does not appear so.
Okay, Chris, I'm assuming you're not providing the,
As far as everyone here, there is a freeze on people, as I understand, going into specialty courts until this Prop 36 is resolved. They're still in place. I was told today that they've charged 30 people with this new felony, of which only 6 have sought treatment out of the 30. I'm not sure how, that's probably changing, or what the date was from when that number came, so it's fairly recent. I did go to an Dictionary and Convention Court graduation last Friday, so they're still having those, so we're still having some success there. And then I hope this Prop 36 thing something gets put together.
Question, and if it goes down a rabbit hole, we can talk offline, but out of the 36, so I'm assuming there's some competency or something, to ensure that people can actually say, I don't want it, like that they're in,
That they would be represented, I'm assuming they are all represented by an attorney
who said,
who
yes, I believe
has
they
talked to their client
Okay.
and adequately informed them as they're required to. Now, it's possible that someone every now and then doesn't want an attorney, wants to represent themselves. And so that would be a decision they'd be making after having refused counsel, because we do provide free counsel through the Public Defender's Office or conflict firm in criminal cases.
But you have to be competent to represent yourself.
If you're not, well, there's a process for that, which a judge will ask questions, called the FREDA process. And so the court has to ensure they are competent.
Okay. So that would never be an issue for somebody who's representing themselves.
Yeah,
They would be
assuming that the
competent.
court doesn't miss something.
Okay.
Nothing's 100% perfect.
Yeah, I keep hearing the public defender, and I have nothing, I mean, they're lovely people, and I have no issue. It's just, I'm curious that if, somebody is really, if they suck, because a lot of people with mental health are not able to understand their disease. So they're going to, just by definition of their disease, they're going to turn away care. They're going to not, and so I'm curious if there's anybody assessing from that perspective.
They do have the right to reject care. We see that all the time in the criminal justice system. All of our specialty courts are technically voluntary, although there is a coercive element to participation in a diversion program or any specialty court, because they've been charged with a crime, so it's never 100% voluntary. But there is a process for that. And so and then there's a concern about the quality of representation from the Public Defender's Office. I've worked in that courthouse for 3 decades. Some of the better attorneys are with the Public Defender's Office, and some of the private attorneys that walk in there don't appear to know what they're doing or understand the Yolo County systems for their Yolo County clients.
I guess where I'm going with this, I'm just thinking of education, and obviously it's not this purview, but it might be helpful for public defenders to go through some of the non-training that really talks about mental illness and really some of the things, so that maybe they might be able to figure out, wow, maybe my client really is not able to make a determination in their best interest. I'm certainly not saying they need to be conservative, I'm just saying that that's a lot. That's only 6. I mean, that really speaks to a lot, and there could be lots of reasons for that. I get it. We're all allowed to make poor choices, but there's just something.
Again, that was the number that was given to me. I had called and asked for an update on that.
We can't forget it now.
From your experience though with diversion, does that seem like a low number to you, or does that seem like that's about right?
I don't know who these individuals are.
Okay.
It would seem low. But when you're looking at severe addiction, a lot of people don't want to change. And we have a lot of voluntary treatments out there, and a lot of people that are not taking advantage of it because they don't want to. Or they don't-
have insight
they
because
don't-
their brain won't allow it.
That's the other component, is they have to have that insight. And I will say that I went to a mental health court graduation last month, and it took about 3 years of the defense attorney working with an individual to get to that insight where that person was willing to engage and do the treatment, engage in the medication. Now they're successful, but so it's not like you have one conversation. Sometimes it takes a long time working with an individual to try to get them to buy into one of these programs. And it could be the same thing with the Prop 36 treatment. Again, I'm not there, I don't know what those conversations are.
Just thinking how we could support public defenders and do they have knowledge, are they all of that thing, and I don't know.
I don't know what internal training they have on that.
I don't know how we would find out either.
I can ask supervisor of the mental health team.
I mean, 6 is great, it's a good start, right? I mean, we'll see how that goes.
This is, again, their field is they fly it,
Yeah, building it as we go, I get it, yeah.
like a lot of rubber bands and all that.
I just want to say, you brought up a great point about like competency and awareness because, I guess like I've experienced having kind of like my awareness or competency questioned, right? But as someone that has experienced that, I'm like, yeah, there are definitely cases where people are not aware, but then externally, people maybe are not educated or trained in how to recognize the difference between this person is kind of aware of their choices and they're just maybe not making the best decisions versus this person is completely not aware of what choices. Yeah, or what they, this person is completely not aware of the choices available to them, and if they kind of weren't in the right, or they were in their kind of like healthy state of mind, that they would have that awareness, if that makes sense. So understanding that differentiation is really important, and then I think, like, as your point goes, like some, maybe like prosecuting or defense attorneys might not like be aware of that difference.
Yeah,
But it's
I believe they all
pretty key,
want
yeah.
the best thing for their client.
Yeah.
Hands down believe that, it's not a question of that, it's just if you're unaware, you're not aware.
I think there's a lot of external factors for that population on housing, on transportation,
Oh, they'll have very.
all that to participating in any of these programs.
It's just that, I never say it right, but it's a real thing. Thank you.
Chris, will you continue to provide updates as you can get them, or?
I will, what I will do is I call my counterpart and I have the counterpart in the public defender's office who I've talked to periodically.
Okay.
One of the things that Joe Goki is the supervisor for the public defense mental health teams. He thought that they could get more people into the DSH funded diversion program. And so that's something that could be expanded because that's state money. As I understand, it doesn't cost the county. And that would put 5 people that would probably be full service partner level services, which our numbers have gone down a little bit into that. So I think they're looking into that. That requires all the agencies to agree to it. And then we have to, of course, fill it.
Is that a presentation, I mean, not clearly our next meeting, but maybe somewhere in the future that we could have, like for the public defenders?
We could probably get someone from the public defender's office and the DA's office to do a presentation on if you're looking at
Diversion and all
the specialty courts of diversion. It's a very complex,
that.
I can talk about it for hours, but,
Yeah.
And Karen and I think we're just so supportive of them.
Right,
Make sure they know we're supporting them, what they're doing is awesome.
yeah, I think it would be good.
yeah, a lot of these programs are a collaboration, which is both the DA and public defender have to work together, along with treatment providers. So it's all the county departments, again, it's a collaboration. And it was a long process to develop trust amongst the different county participants.
Just the time that I've been on this board, there's been a lot of change, and not to the positive, right? Because we started in a place that was headed in a good direction, but not where we are now. It's much better.
Mental Health Court started in 2013, and the programs have evolved, a lot of different ones have evolved since then.
Go ahead. Hopefully continues.
Unfortunately, they're all frozen right now.
I know. Okay, so ad hoc committee, so the nomination committee, I spoke to Nikki this morning. We are going to bring to this board for the next meeting, because we were very premature in the work that we were doing, since we're not voting until late June, early July, or it's effective July, so probably the June meeting. So that's the update on that. Does anyone have an update on the site visits?
So we talked about the form and what we're gonna use. I know you provided what you had, but it doesn't match up with what you guys used when you went out on the last site visit. I was just doing a little comparison
Yeah.
today. So we just have to determine what form we're gonna use and where we're gonna go next. We talked about going on some visits at the hospitals or something.
So we've been trying to coordinate something with Heritage Oaks and Sierra Vista hospitals, and there's a few different sites that like a big tour. It's supposed to be next Friday. And just in terms of like communicating back and forth with them, it's like, can we confirm this? Can we confirm it? Can you tell us how many people can go, right? And we're still waiting back to get confirmation, right? So I'm not sure how many people can realistically go, and as soon as I have that information, I told Jonathan I would make sure that you guys are informed about that. In terms of like the site visits that I think that you're talking about, those are more about our contracted providers, right? And so some of these sites that we'd be visiting are sites that we have contracts with, and others are just sites that they wanted us to be able to see, and we had expressed an interest in. So I don't know if it would meet the same definition. This is more like just like a tour, right? Not necessarily for you guys to do like your comprehensive look. I provided documents that I thought were the right ones, that like if you need something different, then we can do another look.
What's her name? She was gonna look at the form. She's not here tonight. That's,
Are you talking about Dee?
yeah, Dee
Yeah.
was gonna review it and then check it with you.
Okay.
So,
My understanding is from Carlene was that when you guys are ready to do a site visit, that it sounds like traditionally the mental health director would set it up for you guys, just not send your understanding.
The last time, we would communicate with the
Okay,
site we're visiting through the mental health director, like we don't go and contact them ourselves.
Right,
We'll
right.
make Carly, we're interested in
Right,
Safe Harbor, and then
right.
we
so which site are you guys looking at, or have you made a decision right now?
we need to make a decision because we keep
Okay.
putting this off. It's been several months. So, I know last month we talked about what would the board members like to do, which site would they like to go to? So,
And we can do a whole long list.
yeah. So what do you guys think?
What do I think?
Look, everybody as a group.
Like, that's your decision.
Where do we want to go next?
I'm just pulling up a list of what we do. So, the county jail, 3B North in Woodland, Fourth and Hope, Communicare. Those were previously suggested.
Okay, what are you getting?
Seems like a good.
Chris has got a look on his face like, huh, I'm not sure about that.
I was trying to figure out who to call the jail. Unless you guys are-
Careful,
So I apologize, we're talking about visiting the jail?
I think you want to see what the mental health, the jail has just done a bunch of construction, they have a new health wing and mental health area. There is the JVCT, which is the jail-based competency program in the jail, which is for people who are not competent to stand trial due to mental illness, or they're restored to competency. So there's different things in the jail. We're probably focusing on mental health issues, so what is there's a certain treatment area they have for people who are in crisis, there's an ADSEG component, sometimes
don't know if it was so much about people who lack confidence in how, I think it was more like the crisis, like what happens when someone comes in a crisis. I don't know what unit that is, but if I remember from past
Did you talk
dialogue,
about
that
doing
was,
science
yeah, if you remember.
and having them answer surveys?
Excuse me?
Didn't we have them answering surveys for last site inspection?
We did do a site inspection, we did a site visit, but I haven't been to one yet. It was just, we've only done one so far. So now we're trying to figure out what the next place.
Yeah,
So there's a couple of people been added to it.
so essentially when we went to Safe Harbor, like the director gave us a tour of the facility and then we talked to the consumer.
Did they do the survey that we had written up? Didn't we do a survey?
There were questions that we
Yes.
filled out, and then I directly asked the consumer some of those questions,
Right,
and then
right.
I filled it out, so and we talked to them like separately. But like, we were filling it out, the consumer's not filling it out, and then the director's not filling it out, like, we're the ones writing things down.
More interview-based.
Yeah,
So I'm not sure if this is, I don't know, maybe we would talk to a consumer in jail. I think it was, there's a concern, there was concerns last year because this was a program that was just starting and how were people in crisis receiving mental health services
In jail.
in jail? And so I don't know if it's appropriate for this, or maybe it's more of a presentation instead of us visiting.
I would imagine that the jail staff would have additional security concerns if you were meeting a consumer
Yeah, that makes
in
sense.
the jail, possibly one that's in crisis, as opposed to getting a tour of the facilities and what their process is.
So maybe
I'm
it
willing
should
to,
give us a presentation on the process.
Yeah, I think that might be more.
Then a visit.
Okay.
I mean, I
We
think
did have
anyone in
concerns.
crisis in that moment, it's really hard for them to be kind of under the bubble.
We did have somebody come from the jail to give us a presentation. Were you here for that presentation?
But I think it was a while ago.
Oh, okay, so you're thinking an updated one.
Right.
But really, what is the process when we have crisis? Because there was a lot of, we're rolling,
Okay.
if I remember.
If we are going to be doing and evaluating services, actually going into the jail and looking at it so we understand what it is, it's going to be helpful at some point. The idea is to get a presentation on the process and then have some, if some individuals want to go in and actually see it, we can get permission from the jail to do that. Might be the way to go.
Mhm.
To have a presentation first, so you understand
What you're looking at.
what you're looking
Right.
at, and then, who wants to go in and look at it.
That's a good idea, because then you can also, if you have any questions, you can ask them once you get the tour of the place, because you have the overhead first.
Does make sense.
So it sounds like you're saying that we shouldn't do the jail as the next site visit then? That we should-
Correct.
We need a presentation in advance, so if you want a site visit before that, what was the next one?
we also brought up Fork and Hope, we also brought up Communicare, we also brought up 3B North in Woodland.
And Placer County? Placer County,
That's outside,
which is kind of outside.
yeah.
I think before we can go to Communicare, probably get a presentation on kind of the substance use issues in the county, the overview drugs, the
Yeah,
area where Communicare fits in that treatment component and what their theory is, as opposed to going there and then getting the big picture.
Something I wanted to kind of bring up before we switch topics to try to find like another potential site visit location. So in terms of like getting consumer feedback, like of people that have recently been in crisis or are like in a crisis unit, I want to say that like consumers are more able and willing to give feedback than is outwardly kind of like,
We may be able
You know?
to facilitate getting consumer feedback through participants that are willing to do that are in the Connections to Care, which is the Prop 47 funded diversion program, which has Communicare staff providing the treatment, or the mental health diversion, which also has Communicare staff doing the case management treatment. If you're looking to engage consumers, that's one avenue.
yeah. But I guess what I meant is there shouldn't be an assumption that because people have gone through like this level of crisis that they wouldn't be willing to give feedback, I think it's important to kind of like gauge directly and then go from there. If no one wants to give feedback, then no one wants to give feedback, but then I think we shouldn't make an assumption ahead of time, being like, oh, a person within this kind of facility would never want to give feedback or talk with someone.
And that's not what I was
Yes.
suggesting, I was more.
Yeah, I know, yeah.
So,
Yeah, I understand.
because I think about my brother, and like, when he was in crisis, there was no way he was gonna be talking to anybody with any clarity, so.
Yeah, but what, I guess my point is like, it depends on the individual, it depends on the situation, and there are people in those situations that are very willing to give feedback, so.
No, and that's a good call out.
Okay, so it's been narrowed down to two places, right?
3B North, one, like the Davis Walk-in Center, Fourth and Hope.
Oh, there's 3 places.
Okay, so 3B North,
3B North, Fourth and Hope. And one of the HHS.
I hope the next one starts with a 5.
And 5, the Davis HHS Walk-in Center.
Okay.
Or there's one in Woodland, correct? Yes, no.
So,
Yeah, I think so.
The behavioral
walk-in
health clinics.
walk-in
Yeah,
walk-in
behavioral
center.
clinics. The behavioral health clinics.
Yes.
We do have one in Davis, Woodland, and West Sac.
Where's
Yes.
the one in Woodland? Is it?
Right
Right
next
over
door.
there.
Yeah.
Yeah,
I think I'm gonna vote for the Communicare.
Was
Oh,
it
that was
suggested
not
Chris,
on
that
there.
that
you
wasn't
have
one,
a,
that wasn't one of them, so 3B North.
I might suggest with Walter's house, have they finished their move?
I don't believe they have.
Okay, that's probably a bad idea until they finish that move. I thought they were supposed to have.
You know, I'm just getting back after being out for a few months, and so I'm gonna ride that for another couple of weeks.
I'm not fully up to speed with that either. I thought they were moved. but-
So, yeah, I'm just thinking that it wasn't,
I-
complete. So,
We'll get back to you on that. Yes. I
but
And I
there are
apologize
still
for
3
that.
other facilities.
So would it be a good idea for Tony to start sort of talking to people? and
I just need to know which ones you want.
Okay, you wouldn't just focus on one.
I mean, we
instead of,
don't have to
figure
do
out
those
which
3.
one.
We talked about an array, like I would really like to go in and see what's happening on the inside. I won't be able to go, I'm gonna be gone next Friday, so if somebody else were gonna go with you on that tour, I would have loved to have went on the tour to see what goes on the inside of the process. So I don't know if we have that option to go to another hospital instead of going in as a, on a tour, could we go in as a visit, like,
It may be going into one of the county offices, seeing how it's structured, going into the wellness center, seeing how that operates. The wellness center, do we have them in all 3 cities at this
Yeah, we
point?
do.
So, with budget constraint, they may be on the chopping block, so I think that's actually going and checking out one of the wellness centers. If you're from West Sac or Woodland or Davis, you can go to the one in your community possibly. And that'd probably be the easiest thing for you guys to facilitate.
I'm never interested in easy. Like, how many, you do the site visits, how many people go? Is it 2, 3?
As many as will show up.
Oh,
Just
I
usually
thought
two.
you were trying to limit it to.
yeah, no, it was,
I
Oh,
think,
so we can?
I think so.
Okay.
No one's-
what happened was initially there was 3 of us that signed up. And we had one lead, and then she's no longer here, and I was asked to be the lead, that's why I was just trying to
I would-
bring it on.
I would advocate for not, like, even like the tour that we've been invited to participate in, but we don't want to bring this whole gaggle of people through, right? I mean, it could be very disruptive for the program.
What do you think the max should be?
I mean, I'm reluctant to say without knowing the program
probably
specifically, but
just
I would probably say like 3. You know what I mean? That would be my guess, but like.
It may vary by the site too.
And I would say it would vary by the size.
I would
lean
defer to the provider. That's why I keep asking them, how many is the most we can bring, you know? So why don't we do it this way, if you guys are okay with it, right? What are your top 3? And I'll start reaching out to them and trying to set something up.
I think those are the top 3,
The
right?
the walk-in centers, 3B North and Fourth and Hope.
Does everyone agree on that, or?
Sure.
Let me ask you this, what if we did the 3 wellness centers and we did them like 15 in and we compare, like how different are they? Like, so if we did all the 3 wellness centers.
How
like
about,
different teams.
how about if we do this? I feel like
That is a
we're
good
doing a little bit
idea.
of horse trading now, right? I will call 3B North and Fourth and Hope, and then internally we can work on any kind of county facilities, like, and kind of figure out like what would be the best fit above one of the three different wellness centers, right?
Okay.
And I'll get back to you kind of on options around that.
That'd be great.
Okay,
And then you can get the volunteers list, so that when they decide how many people can go and how many people that already volunteer.
yeah, my plan will be to kind of get a list, my plan will be to get a list of options, right, and dates and kind of points of contact and kind of what the maximum number of people it would be, and then we're gonna go from there. Now, normally, you don't need county staff with you when you do stuff like that, right?
Last time we did, we just,
Okay,
we
all
just
right,
showed
all
it.
right, just check, just check,
And
okay.
Nate, you're still on board with that, right?
I don't, yeah, I don't need to go to 3B North, but yeah, because someone else can take my turn, been there plenty.
And Maria, you wanna go to any of the site visits? I'm trying to get like, who's all,
So I'm
Yeah.
interested in site visits, but then there might be a few that there's a conflict for me, and I'm not gonna go.
and that's why it's good to have a nice little
Yeah.
group of us that we can kind of rotate.
It could be that some people are more interested in one location than another. I've had a tour of 3B North, I don't need to go there again, but someone who hasn't been there, I think I'd
Yeah.
encourage everyone to take a look at that place, because that's the one facility in this county. And that's, one of the areas that we should be really concerned about.
And we might also want to consider an ER.
I would love to do an ER at some point, but I haven't done that.
Well, to do site visits in the future, but Friday's different, that's gonna be something that they're gonna be doing a tour.
So I just want to be really conscious of time because it is 7:57. And we do still have the long range plan to talk about. So is the takeaway for the site visits that, Tony, you'll get back to us, right?
100%, yeah.
And then in the meantime, anyone who is interested in going, maybe they could communicate with Kimberly so she could develop a list. And then we'll be ready to go once we have the go ahead. Does that make sense?
Yep.
Is everybody good with that?
Yep.
Okay, so we have the long range planning calendar. And you have it then, there's a lot in here. Is that ours or yours?
The long range planning calendar?
It's on as an agenda item, so I wasn't sure if this was something you added or maybe.
I don't know why it's on
I
there.
think we talked about just getting suggestions for presentations. We can table that.
I remember, if I remember correctly, Carlene had created something for you all.
She sent out something about what we talked about last time. I think this is almost like a workshop, because that's kind of what we did last time.
Right.
Um,
And I think Christine.
yeah,
Yeah,
so let's move that, not the next meeting, Christina, so when you get this video or audio. If we can move it to 2 meetings out, because the next meeting will be focused on,
the
I think we
innovation
need to spend a couple of minutes on the next meeting, because we need to figure out the additional topics that we need to schedule.
for at least the next meeting,
Yeah,
next few meetings.
we've had some proposals for presentations that we want,
Yeah.
if we want to get those scheduled, we need to start working on that.
Yep.
Unless that's something the executive committee would kind of do on their own.
Yeah, I wonder if that would be a good idea for us to just put together a calendar, bring it back to everyone and ask, is this what?
For the
you want?
next meeting, that's what we'll put together and then get feedback. I like that. Tell John. Okay, we have one last, final public comment opportunity.
I'd like to make public comment. I don't know if you can hear me.
Yes.
Yes, Christy, go ahead.
Hi, Christy Korea. Hello, everyone. Good to see you. I just want to strongly encourage the board members to review the contracts, the current contracts that are in place with these providers ahead of the presentations and ahead of the site visits, just for a number of reasons. To me, it's important to know what the scope of work is within the contracts. it will allow you to understand the services better in detail and are they performing, the duties that are stated in the contracts, understanding the fiscal environment that the county's in, reviewing those contracts and seeing if the county's getting the value for the dollar. Also, looking at metrics and reporting data and looking at future contracts with these providers incorporating those deliverables in the next contracts. I know WellPath is the provider in the jail, and there's been some discussion, I don't know the last time that contract was really reviewed by the board. So I encourage you to please look at the contracts before the presentations and before your site visits. Thanks.
Thanks, Christy.
Mhm.
Any other public comments? Okay, so we have our meeting scheduled for our next one will be April 9th and not 2nd, and otherwise we are adjourned.
We have all